I'm going to introduce Dr. Matthew Wilkening, orthopedic spine surgeon who performs surgical, lumbar, thoracic, and spine surgery. He's interested in helping patients to find both surgical and non-surgical solutions for all conditions affecting neck and back. He graduated from the U.S. Naval Academy in Indianapolis and served as a pilot in the U.S. Navy. He went to earn a medical degree from the University of Cincinnati and College of Medicine and completed residency in Michigan State University in Grand Rapids, Michigan, where he is named Intern of the Year. Dr. Wilkening completed his spinal reconstructive surgery fellowship at Johns Hopkins University in Baltimore. He's presenting research in spinal deformity, trauma, minimal invasive techniques, and oncology, a variety of national international forums. I welcome Dr. Wilkening.
Well, hi, thank you for having me. I wanted to share an exciting new treatment in spine surgery that's really becoming quite a bit more commonplace, and I think is going to really change the paradigm a lot of ways in which we treat patients. You saw the title, Endoscopic Spine Surgery, Maximum Downtime or Minimal Downtime, Maximum Upside. And so I'm going to share my screen with you and we can start this presentation. So I think this is the thing that I share with you.
Correct.
All right. Can you see this thing now?
Yes, you are good to go.
Very good. Okay. So this is the tool that we use, and I kind of put this thing up as my very first slide because that's the tool that we use, and that camera is about 6 millimeters across. So this, if you can see my cursor on the screen, this area is about 6 millimeters across, and that's really a game changer because that's the size your incision needs to be for surgery. These are my disclosures, and I think it's important to know that I am a clinical instructor for Arthrex, who is the company that manufactures the most of the equipment that I use for this tool. Now, I was using this tool for quite a while before they named me as one of their instructors, but I think that is important to understand. So this is an observatory, and I like to start with an analogy when I start these presentations. And this is a land-based observatory, one of the best observatories in the world for seeing into outer space from Earth. And this is one of the best pictures that it can come up with. And you see all the detail in the stars and supernovas and all these things we can't see with the naked eye. And this is the Hubble Space Telescope. This is the sort of pictures it's able to create. And if you imagine, this is zoomed in on a very tiny part of the picture that I just previously showed you. And this is akin to endoscopic spine surgery compared to open microscopic or even microscopic spine surgery. The amount of detail and the amount of precision that you can enjoy using endoscopic spine surgery is significantly higher. Just as it's fairly easy to get lost, as it would be easy to get lost in the heavens from this perspective. So it does require a little bit of a learning curve, a little bit more skill, but it also is able to provide a significantly better product for patients. It's not brand new. This is the original endoscopic surgery. It wasn't a spine surgery. It was a 42 millimeter long, 42 centimeter long rigid scope that was placed down and looked in the stomach on an awake patient. I was placed right down the patient's throat, so I kind of showed this the sword swallower here, and they used a light source that I'm not sure how they were able to even see anything. So that's where we came from, and that was done in the 1800s. the endoscopic surgery or laparoscopic surgery using cameras to see what we're doing inside the body, then went through a variety of evolutions until really the first intralaminar and transforaminal endoscopic spine surgeries were performed in the early 2000s. Now, those were done using different tools, and the tools and techniques have come a long way since then. This is really kind of the frontier of endoscopic spine surgery when people were learning how to do it. And now, 20 years later, we sort of benefit from all the learning and maybe even mistakes that they made along the way, figuring out how to do this safely. The future holds robotics, 3D scopes, and navigation, making things even safer and even more capable. So that's very exciting. There's a few different definitions for endoscopic spine surgery, and they're basically fall into three different categories. One is called full endoscopy, and this would be one scope, one incision. The entire surgery is performed through one small incision, and this is kind of what is becoming commonplace. This is the way that I think it's done best. Biportal endoscopy involves two small working channels, a similar scope, and then a small working channel if a little bit of extra dexterity is needed. And then microendoscopy is more of a larger channel where and it is approaching the size of a microscopic surgery where a camera is used through a larger channel. This is almost a hybrid between microscopic surgery and endoscopic surgery, and it's becoming less used. Put this picture on the screen because it's always curious to know, how does the scope get into the spine from the outside? So there's a car and a goat that kind of make you wonder how they got in those positions. And the approaches are either coming in from the side, the transforaminal approach, the interlaminar approach, and the thumb and the lumbar spine. The thoracic is only the transforaminal approach, and then the cervical is only straight down through a foramen in the back. These are some visualizations of it. So in the cervical spine, you can see this scope comes down and makes a very small 7mm incision, and it can be used to decompress a spinal nerve root. Now, I'll discuss this with you more later, but this is really groundbreaking as far as helping patients to avoid fusions. And I think that's going to be very beneficial to all patients. Fusion is a good operation if it's necessary, but prior to endoscopic surgery, we were either talking about making a very large incision to do a very small bit of work, or going in from the front and doing a much less invasive surgery from the front, with the caveat that you had to take out the entire disc and then replace it with something like a disc replacement or a fusion cage. By making this incision smaller in the back and using the endoscopic surgery, you can really kind of find a much better treatment and minimize the damage that's done through the posterior approach. Thoracic surgery, and this is one that can be done safely, but is kind of on the more dangerous side of the surgeries. Thoracic discs can be accessed with great care given to avoiding the spinal cord through a transforaminal approach, so almost through the side and avoiding ribs. It's a fairly difficult approach, but it is not impossible. And when appropriate, I'll show you a case presentation at the end that will really kind of emphasize why this approach can be distinctly helpful for patients. Lumbar tends to be the main working horse, and there's because the spinal cord is now turned into a bunch of nerve roots, and a cannula can be placed into the spine, and the nerve roots can be gently nudged out of the way, and a disc herniation can be resected either through an interlaminar approach or coming in from the side. Tends to be a very kind of where you get the most bang for your buck out of it. The interlaminar approach allows us to avoid the posterior elements altogether, which does allow us to do decompressions of disc herniations that prior to endoscopic surgery being a possibility required removal of the joint. And if you have to remove the joint, then you have to do a fusion. This is a very important stabilizing factor. And so if a disc herniation is right here, it's very hard to get to it from any direction. With an endoscope, and you can put a scope down and get to that disc herniation, it allows us to avoid resecting the joint and can help those patients to avoid a fusion. The last thing that is also a unique approach to the endoscopic spine surgery is the medial branch transection. And this involves putting the camera down and finding that medial branch nerve that causes pain to be experienced from the arthritis on the back of the facet joint, and really just resecting that tiny little branch of the nerve. Really, the only useful sensation you get from this joint is pain, and it can be not particularly useful when it just reminds you constantly that you have arthritis. So if you have a patient who has arthritis in their back and they were getting along just fine until they sustained a workplace injury, and then they can't ever quite get back to where they were before until you denervate this facet joint. It's a very minimally invasive way to help a patient achieve improvement of the symptoms that were aggravated by the work injury without trying to treat the entire pre-existing condition of arthritis. So it's a very powerful treatment, and it has a distinctly longer duration of relief compared to radiofrequency ablation. So radiofrequency ablation lasts anywhere from 6 to 9 months. The endoscopic medial branch transection lasts at least 2 years in most papers, and that's probably because those papers were only written over the course of 2 years. It also allows you to directly visualize the nerve and avoid denervating the muscles by resecting the lateral branch, which actually provides muscular force. So it's a very powerful treatment for back pain. The advantages of endoscopic spine surgery is the main advantage is one of the main advantages is that the incidence of surgical site infection is almost negligible. And it makes sense when you think about that you're irrigating fluid in order to be able to see through the camera. It relies on a constant source of clear fluid. So you're irrigating the wound the entire time. And that just almost completely prevents any sort of infection. It can happen, but if you see a microdiscectomy has about a 1% rate of infection versus a 0.01% rate for endoscopic discectomies. 1% will require an additional surgery, degraded improvement from the surgery, and it certainly can lead into some down a path of multiple surgeries and multiple complications. And so even though it's only 1% that get infected, this is a distinct advantage. The second advantage is significantly reduced surgical morbidity. And this is most pronounced in your obese patients. And I'll show you some pictures where you can see that the incision is the same size. Because the camera is put through a cannula that goes right down to the spine, it takes my eyes from 2 feet away from the patient's spine to right on top of their spine. There doesn't need to be a big incision in order to move all the tissue out of the way. The incision is the exact same size in an obese patient as it is on a very small and fit patient, because all it has to do is make room for that cannula to get down to the spine. Another significantly reduced morbidity of surgery is it permits foraminotomy, meaning opening up the foramen, the space for the nerve to transit, without disrupting the back of the spine, the stabilizing joints and ligaments on the back of the spine. And many times, if we have to interrupt too much of the ligaments and joints on the back of the spine, that can cause the spine to become unstable. So if you see the patients that have a discectomy or even a laminectomy for a workplace-related injury, and then 5 years later need a fusion because their spine has become unstable, and over 5 years, a spondylolisthesis has developed, and the work comp carrier is on the hook for not only the laminectomy but also the fusion surgery, because the laminectomy is a result of the work injury and the destabilization as a result of the laminectomy. You can see why a endoscopic surgery that does not disrupt the posterior ligamentous complex, has as much less resection of the posterior ligamentous complex, has a distinctly lower incidence of destabilization and the need for fusion at a later date. And that kind of dovetails nicely into the fact that it may allow a simple decompression in patients who previously would have needed a fusion. And I will show you a patient later that had a grade 1 spondylolisthesis, and we were able to do a discectomy on him without destabilizing the posterior ligamentous complex, and therefore he didn't need a fusion. We were able to take out the disc that was causing his pain rather than needing to do a fusion because of the destabilizing factor that would happen via traditional surgery. The important part of that is that reduces a patient's permanent impairment by up to 50%. So if a patient gets a fusion, their permanent impairment rating is at least somewhere in the 20% range. Whereas if they get a discectomy and they have even some mild persistent or even moderate persistent radiculitis afterwards, they're still in the 12, 13, 15% range. So that's a significant reduction in their permanent impairment. And it doesn't induce the adjacent segment degeneration that a fusion does. So if we're able to decrease the amount of fusions that need to be done for workplace-related injuries, then we can really cut costs significantly. There is also a decreased complication rate. However, that is learning curve dependent, just like any new surgeon that comes into practice has a little bit of a higher complication rate than an experienced surgeon. A surgeon doing the endoscopic surgeries will have a slightly higher complication rate early on, but eventually their complication rate is actually lower than the traditional open surgery, mainly because of the visibility. When you can look and see the nerves and they look enormous, you can really avoid irritating the nerves significantly. So these are our primary advantages of endoscopic surgery. This is a patient, and this just goes to emphasize the lack of a need for a fusion. This patient had multiple level, a workplace-related injury, who had multiple level foraminal disc herniations that were crushing his nerves. And this is a patient that I would have had to do a fusion on before, because in order to get this out, you can see this disc. If you guys can see my cursor, if you see this disc is occupying the entire foramen. And the only way to get that out is to take out the joint to get that disc out. And similarly at this level. However, when we can put an endoscope in that comes in at an angle from out over the flank through a small incision. I couldn't do an open surgery this way. That's just too much dissection. That would be too morbid. But an endoscope that can go in and can show me this disc and allow me to get to that allowed me to avoid doing a 2-level fusion on this patient. He just had a 2-level discectomy, and he got better and returned to work within 8 weeks. This is the size of the incision, so you can see my hand. And I have another picture later on. But this young lady and this big old guy who both have disc herniations had the exact same size incision, right? So this guy, we barely had a cannula that was long enough to get down to his spine. In this patient, the cannula was sticking out way out of the back. But it doesn't matter, because all we have to do is make room for the cannula to go into their spine, and we can take that thing out. So there are some complications that we have to keep aware of, and we do have a little bit of a higher incidence of postoperative radiculitis and pain in the short term after surgery, because we are putting a little bit of extra pressure right there on the nerves with the cannula. So we've noticed that. However, that does go away. If a durotomy happens, meaning an opening in the dura happens, we do sometimes have to open that patient up and actually repair that dura. And that's possible, although that is rare. And many times the durotomy doesn't have to be repaired, because the minimal dissection allows the body's compensatory mechanisms to close that durotomy by itself. Surgical site infection can happen. We discussed that already. Reherniation can also happen, or incomplete decompression. Sometimes if you're only taking away a very little bit of the spine to get in and find that disc, if you get most of the disc, there can be a small piece of disc that that can escape your view because you don't see the whole thing. That's rare, but that also can happen. And most patients find that it's worth the significantly decreased overall surgical morbidity. And the other problem is the capital expenditure that surgery centers and hospitals have to undergo in order to buy all this equipment, because it's very specialized equipment. And in order to buy just a couple of operating sets, it's in the hundreds of thousands of dollars for hospitals. So they have to have a commitment to this, and a surgery center as well has to have a real commitment to this in order to be ready to do it. Here's some cases, and I think I'll show you these cases, and then I think they will induce some questions. So after I show you the cases, I think I'll open this up for questions. This is a patient that came in, and this was not a work comp patient, but I think his surgery is really instructive of the capabilities of our surgery. So he came in, and he was wearing dirty Crocs and gym shorts, and he didn't have insurance. And I said, well, I'll get you set up with charitable care, because he had a massive disc herniation and he could barely walk. And he said, well, why don't I just pay cash for it? And then I realized that he could afford many things. And so we did his surgery 3 days later, and we were able to get a very large disc herniation out. And this is what it looked like when I got in there. This is my little 3mm kerrison that looks massive on the screen. And then this is his nerve that's just fully decompressed afterwards. He got instantly better, and I saw him once after surgery, and then he just let me know he'd call me if he needed me. So I was very happy with him, and this is what we were able to take out. In fact, this was so big, I had to take all the equipment out because I couldn't fit it through the cannula. I almost had to make a bigger incision for this. And that's actually, I thought, wow, that's an amazing situation. That's actually become more common. I've had several discs at this point. I've done probably 60 of these, and I've had probably maybe 7 to 10 where I've had to take the equipment out because we were able to get such a big disc herniation out that it was actually bigger than the cannula. It was eye-opening. This is a young man. This was a workplace-related injury. Very similar situation. And I thought I showed you the still picture. So in this one, I was smart enough to start the video recording. And you can see this gentleman, he fell off the back of a work truck. He had significant left-sided pain, weakness, and numbness. And he, again, also could barely walk. And I saw him in my office with his new wife and his brand new little baby. And I said, man, we are going to get you taken care of. I was very partial to getting this young man taken care of. And so this is what it looks like. So that's what a disc herniation looks like. And I wanted to put this video on the screen because this is the old school open version of it. And then I'll show you that gentleman's surgery after this video. But this is the old school open version of surgery. And this tool is probably the same size as my endoscope. And this is a microscopic discectomy that I did a couple years ago through a fairly small incision. And you can see we have all these tools in there, and we need all these tools. You see the amount of bleeding that has happened, the amount of dissection that we have to do in order to just get access to this space. And this is zoomed in really big on a microscope. But even with this, you just see how much larger, or you will see in a second how much larger. So you see this is kind of an equivalently sized disc herniation. You'll see me pull out of this guy. So this rondure that I'm about to put in is about twice as big as the rondure that I used through the endoscope. That's the thing that's grabbing the disc. And you see we pull that thing out, and we're able to get it all out of there. And we have a great happy moment because we know the patient's going to feel better. We're able to get a little bit more out of there. I think I even give a thumbs up at some point. That's kind of silly. But we can move on from that. This is what it looks like on the endoscope. And this is you can see the nerve root, and you can see all the disc. And the first thing you'll notice is it's a lot cleaner, and there's a lot less bleeding. We really have a very minimally vascular plane that we're able to create. And you see that tool, it's about half the size of that kerosene or that pituitary arrangement that I had before. And this disc herniation is about the same size as what I took out, but now you see it got stuck on the camera and I had to pull the camera out in order to get that thing free. And that was actually that young man's disc herniation that I just showed you. And that's what it looked like. And this is what we were able to measure afterwards, how big we were able to get out through just that small incision. If you see the diameter of the cannula is 7 millimeters. So 7 millimeters, here we are. And this thing, we were able to get this thing out through a 7 millimeter opening. Is really exciting. This is the difference in the incision size. So these are two patients that I did, one through the, and both were workplace related injuries. This one was done in 2021. And he had a microdiscectomy and was able to get back to full duty after about 12 to 14 weeks. This gentleman was able to get back to full duty after about 6. And you can see the difference in the incision. Same exact pin. This one just came in as a long-term follow-up. So this is probably a couple of days apart. This is the gentleman, a gentleman that we did a transforaminal discectomy on. And if you look at his spine, the first thing you'll notice is that it's full of arthritis. He's got scoliosis. He's got spondylolisthesis. He's got some calcification of his aorta. So you're worried about that being a little bit fragile. And you think, man, I don't want to do a big surgery on this guy. But if I take out this disc, it's hidden right behind the facet joint. There's no way to get to it. And if I try to take it out in any way, I'm going to disrupt this facet joint. The spondylolisthesis will worsen. And then once that happens, we have to start fusing him all the way up. And this could be a single level problem that turns into a multiple level problem with all this arthritis. Well, for this gentleman, we're able to put the cannula in through the transforaminal approach from the side, and we just took that disc out. So we just took this thing out that was hurting his leg. We didn't worry about the stenosis, the spondylolisthesis. We worried about the one part that was actually just hurting his leg, and he got instantly better. And he was excited to avoid the fusion cascade. He's a very active man. And by taking out just that little piece of disc that was giving him that toothache in his leg, he was able to resume his active lifestyle. He may end up getting a fusion in the future, but that'll come because of something else, not because of a disc herniation that we were able to avoid. And if I translate that into the work comp world, if you have a patient with a spondylolisthesis and a disc herniation that's in the foramen, that's far out in the foramen, that will allow us to take that disc out without doing the fusion, which will be a kind of a significant improvement in return to work, but also a significant cost savings for the carrier. This is a patient who had that we did a endoscopic cervical surgery on. We trimmed out the joint that was causing compression of the nerve root. And again, you will notice on her that if I go in, and the problem for her is right at this level, you see this disc herniation at C5 and 6. You see there's a disc herniation that's causing compression of the nerves right here. And I'm sorry, it's on this side. Just call it the disc herniation here. This is just bad stenosis, but the disc herniation is on the right side right here, and it's causing compression of the nerves. And if I go in and address this surgically from the front via a fusion, which is really the only appropriate anterior-based procedure, we're going to cause this or do a one-level fusion and be ready to do the next. If I can go in, and which I did with this patient, go in and just trim out a little bit of the joint, take out that disc and free up that nerve root. This patient at her 4-week postoperative appointment was asking me when she can get back to the gym, and was a little bit irritated because she still had a little bit of neck pain. I had to remind her she had surgery. So this was, and you can see the nerve that we're able to decompress. You can see all of the stenosis around it, the disc space we're able to decompress. And this is a nerve. I'm sorry, I don't have a video for you, but this is the actual nerve that's exiting right there. So that also saved this lady from not only one fusion, but possibly a nice fusion cascade. Well, not nice for her. And I think that's really the supreme value in this. That doesn't mean that she won't have something happen at a different level later on that may need a fusion. But if we can put her first fusion off for 10 years, well, that's good. And anytime we can put off a major operation, maybe we won't ever have to do it. Last one I wanted to show you is, and this is a case study that I think most patients or most people who do presentations and most docs would say you don't show your you shouldn't show your warts, but I'm going to show a wart of mine because I think it's really instructive on why I embrace this technology. So this is a gentleman that came in. He's a 51-year-old male. Now this wasn't a workplace injury, but it very well could have been. He was in the gym deadlifting. He decided he was going to get in shape and he was going to do a deadlift. And he did a deadlift and he didn't do it quite right. And he blew out his disc, but he blew out his disc up where he has spinal cord. So this is the 12-1 disc, and he blew that thing out to the point where it was irritating the tip of the spinal cord. Now, the end of the spinal cord is the most sensitive part of the spinal cord. When you operate around that, it's like playing the game of operation. You don't want to touch it. It might hold a grudge forever. It also is very prone to having problems with bowel and bladder function after if it's irritated or insulted. So this gentleman was having intermittent bladder and bowel incontinence and urgency. And we had to go in and take this disc out. And you see this disc decided to settle in right in front of the spinal cord. So even if we were to take the pressure off from behind, it wouldn't really matter. It settled in right behind the spinal cord. And the only way to get this disc is to go in from the side, open them from the midline, carve off all these muscles, go in, take out the disc through what's called a costal transversectomy, make enough room there, and then play chicken with his spinal cord by peeling this disc forward and then pulling it out backwards. You can't go from the front on this one because there's all the critical structures that you can't get out of the way. This would being the aorta, the kidney, the renal arteries. You have to go in and do it through the costal transversectomy. So I did that on this gentleman, and we were able to get his spinal cord cleared off despite some hair-raising kind of reactions from him. And right at the end of the case, as we are peeling off the last little bits of disc, a piece of disc adhered to the lining around the spinal cord, and an opening in the dura developed. So he developed a spinal fluid leak right into this disc space, and then right into all this space that I just created. So we patched as best we could. And we did the fusion because I'd taken out the entire joint and done this big costal transversectomy. You can see the size of the incision with our staples. And he got better. He stayed in the hospital for a couple of days, and he got better, and he went home. And then I got a call on this was a year ago, actually, Memorial Day weekend, Saturday morning. I'll never forget. I'm having breakfast with my son like I do every Saturday morning, and I get a call, and it's from him, and I'd given him my phone number, and he's telling me he's in the hospital and he's getting an MRI. And this is what that MRI looked like. The spinal fluid leak opened up. The spinal fluid leak was causing there to be, through kind of a one-way valve mechanism, pressure on the spinal cord. And I had to go back in on Memorial Day weekend and evacuate this, try to find the leak, which I couldn't find the leak, and then put a drain in his back, which we put that in down at the bottom, which takes spinal fluid off at a measured rate such that it causes the dura to be able to close indirectly. That ended up being successful, and he was able to go home after a week. But this is a second operation and a major emergency sort of operation that had to happen on a holiday weekend with your holiday weekend staff in the operating room, not your normal staff, and cause this guy to have an extra week in the hospital. We were able to get that but we were able to get a good outcome. Eventually, he had no symptoms. He had a fusion, but he had full recovery of all his symptoms. So I did this surgery, and then I went to the course, and I done an Arthrex, or kind of their initial course, and I met a surgeon who's been doing these for about 10 years. His name, or actually, I think he's been doing for about 15 years. His name is Paul Hull, and he operates on a Cape Cod hospital. And I met him, and he said, well, I've gotten so that I can get to these thoracic discs just doing them with the endoscope, and it's much better for patients. And I said, well, tell me more. And he told me about it. I said, well, that's awesome. The next one I have, we'll think about that. So right after that, I had this young lady come in. Same thoracic disc, a massive disc, crushing her spinal cord, nudging it off to the side. And I sent this picture to Paul. I'd done about 3 endoscopic discectomies at that point. So I sent this picture to Paul and I said, hey, man, what do you think about this? And he said, that's a great one for the endoscope. You might want to get a couple more under your belt before you tackle that. And I said, Paul, I want you to do this one. I'm not going to do this. I'm not ready for the big leagues. I'm still warming up. So we got this lady set up down at Cape Cod Hospital, and Paul did her surgery, and I went down and watched him do it. And he did the surgery, and then she went to the PACU and was in recovery. And he said, well, I have another one if you want to watch me do the other one. And I said, sure, I'll watch you do the other one. And by the time I got out of the second surgery, which lasted about 90 minutes, she had already left the hospital. She was already headed home. And it was such a groundbreaking difference between a very similar problem that I had with a patient that I treated in the traditional way with the open costotransversectomy, and this endoscopic treatment of the same problem. One guy probably had a collective 12 days in the hospital. This lady had about 90 minutes in the hospital after surgery. Just such a difference. And I wanted to show you that because I think that really has governed why, has governed why I'm wanting to learn this technology and be able to apply it to a lot of different situations. These are the sources I use. A lot of times I think it's helpful to see those sources. And then I'm happy to answer some questions if you want. That's my email, the cell phone number if you want to get a hold of me. And so open for any questions.
Thank you so much for that webinar. That was great. We do have a couple of questions here in the chat. Does age of patient impact the determination of need of fusion or discectomy?
So the pathology should determine whether they need a fusion or a discectomy. Age may determine whether they are healthy enough to undergo a fusion operation. More patients that have worse preoperative health conditions and more kind of preoperative morbidities with diabetes, et cetera, are able to undergo a discectomy than are able to undergo a fusion. So the endoscopic surgery does open up more patients to being able to have some sort of surgical treatment because the risk of reoperation is significantly lower, mainly via the reduction in infections. So if you have somebody who's in poor health, the infection rate is 1%, except for if you have somebody who has diabetes and poor nutrition and liver issues, and then their infection rate is starting to creep up. But with endoscopic surgery, it's still very, very low.
Okay. Then the second question is, are most doctors using this type of surgery today, or is it relatively new?
So I think the surgery is not super new. It was first done about 20 years ago. This is a surgery that a lot of docs are not using. And this is a technique. And I think because it's got a really steep learning curve, to be honest. This isn't something I learned in fellowship. I think as docs learn it in fellowship, they'll have more doing it. But I can tell you, I'm the only person in New Hampshire that does this. I think there may be 2 docs in Vermont that do it. I don't think anybody in Maine does this. There's a few docs in Massachusetts. So that's what I know for this area, for our immediate area. So 1 or 2 in Vermont, me in New Hampshire, 0 in Maine, and then maybe 5 or 6 in Massachusetts. I think more will embrace it. But I think that that it is something that you will have to travel, that people will have to travel to find. Now, Arthrex has said that patients will travel an average of 90 miles to go to a doctor who does endoscopic spine surgery, if endoscopic surgery is an option. And I will tell you, I've found that. I have 2 patients who traveled down from Vermont to see me, and I have 1 patient who traveled down from Maine already. And they just sort of put my name out there on their Find a Doctor portal specifically for endoscopic spine surgery.
Does Medicare cover it?
So there is some difficulty with some coverage for some of the newer procedures. So Medicare will cover endoscopic discectomies. There's some question about the codes that are used. There's some specific endoscopic discectomy codes, and then there's the basic discectomy code, and with the idea that the endoscope is just a tool, no different than the microscope. The endoscopic specific code has kind of fallen out of favor, and what most carriers, both commercial, Medicare, pay on is just the regular code. When you describe that it's a light-based visualization, direct visualization, that suffices for the code. And it actually, if you look in the coding guides, the most recent coding guides have just expanded to cover endoscopic in the original codes, the 6303 code or the 63047. Some commercial carriers will not cover specific ones. In fact, I recently had a gentleman who I talked to about on a peer-to-peer, and he said they can't cover a 63047 or a 63042. I can't remember which one it was, because it's not covered by their insurance. And I said, well, it's a better procedure. I'm going to save this guy a fusion by doing this. And he said, oh yeah, and actually that's how I had mine done, but I still can't cover it. It still isn't in our algorithm. I think that's changing. There's some fairly powerful forces with lobbying that are changing it, but from the perspective of Medicare, many times Medicare is happy to cover it, but our Medicare Advantage, some of the Medicare Advantage plans will not cover it.
Is there a situation where an endoscopic procedure would need to turn into an open surgery?
Absolutely. There's a risk of that. I've done 60 of these, and I've had 2 that I had to convert to an open surgery. That's about the published rate, somewhere around 2 to 3%. So mine's a little bit higher, but also that's in the beginning of my those are both kind of in the beginning of my treatment. And in that situation, if there's a durotomy where the nerve roots have actually herniated out of the dura, and it's a large enough durotomy, then that one should be opened up and converted to an open surgery. There's also, if you see a disc, or you see the pathology that you're going for, and you just can't get to it endoscopically, then you have to make a decision about whether you did enough endoscopically or whether you need to open it and finish it open. And I've had a couple of patients that I just told them, I think the chances are too high that I would have to open this. So we just did it open the old school way, just because of where the disc herniation was. It was just in a really tough to get to place. So that can happen. An epidural hematoma can occur after surgery. So when you go in with the endoscope, if some bleeding occurs at the surgical site afterwards, and that is causing compression of the neural elements after you finish with the endoscopic surgery, then it's not really feasible to go in endoscopically and open up that and wash that out. You generally have to open it up and make room to evacuate the blood via an open surgery. So that's really the 3 ways that it can happen. Most of my patients, if I think there's a chance, I quote them something like 10 to 20% chance that we're going to have to open it. If I think it's higher than that, if I think it's like a 30% chance, then I just say we should just do it open to begin with, because you don't need to be under anesthesia for the whole time that it takes me to do it endoscopically and then convert it to open and try to adjust it. So if I think it's a 30% chance or above, then I just say we should do it open. And I would say this has replaced 90% of my open discectomies, but it hasn't replaced 100%.
Okay. How does the surgeon make the call on what size disc fragments can be removed through the scope if the call needs to be made intraoperatively? Some of the disc fragments looked kind of large.
So you can get really large disc fragments out. And as I said, I've had to pull all of the equipment out. Now I maintained control of the disc fragment. So once I got a good grasp on it, I've had to take the entire equipment array out of the patient's back. I had one that was kind of stuck at the skin, and we had to work it out through the skin, through the incision, that the fragment was that large. So I have not met a disc fragment that was too large to get out endoscopically.
Okay. Any New York or New Jersey surgeons who do this?
There's a lot of docs in New York and New Jersey. In fact, New Jersey is kind of the birthplace of endoscopic spine surgery. So they have the highest per capita endoscopic spine surgeons in New Jersey. I think Texas and Florida also have quite a bit, and then New York has quite a few that do it, especially in New York City. There's a New York endoscopic. There's an endoscopic only spine surgery group. I think it's Shin's group in New York City. And I worked with a Dr. Telfison at one of these courses and kind of worked on some of my technique with this. And he's done hundreds of these. A lot of these guys were in academics, and they were big professors, and they've decided to kind of settle into a more genteel life of just doing endoscopic surgery and not having to teach residents. So there certainly are in New York. I don't know about upstate, but certainly in the city, there's plenty of them.
What's the treatment for dysesthesia post-laminectomy?
For dysesthesia post-laminectomy?
Yes.
So an endoscopic laminectomy, that's one that I've kind of tightened my indications on, because they can take a long time. That burr that is required to drill out the lamina and remove the bone is really only like 2 millimeters across, and it takes a long time. And so if you have somebody that has that much just arthritis, they're probably quite a bit older. So you probably don't want them under anesthesia for the amount of time it takes to drill all of that out. And B, they probably don't care about a little bit bigger incision. So that's, I guess, for the laminectomy, I've actually pared back some of my indications, and depending on the patient age and how long I think they can sustain anesthesia, a lot of those laminectomies, meaning I have to just take out a whole bunch of arthritis that's crushing the nerves and a bunch of hypertrophied ligaments that's starting to convert to bone. I'll just do a lot of those open. Some docs will do those endoscopically. If a patient has dysesthesias or paresthesias, then usually we treat it with steroids and a neuromodulator like a gabapentin or a baclofen or a Neurontin, one of those, or Lyrica, one of those medications. Typically early on, it's just because there's a lot of inflammation. That inflammation is leaking right onto what's now a naked nerve, and meaning it's had the covering lifted off of it, and for whatever reason that's really irritable. So we'll use a lot of times steroid right at the beginning, like a Medrol dose pack or even a higher dose of prednisone. And then if the dysesthesias and the paresthesias persist, then we can use gabapentin. But usually they go away within a few weeks.
And this is kind of a twofold question. Any surgeons in Florida who do this, and how do you find doctors doing this type of procedure?
So I think the most reputable company that is involved in this is Arthrex, and they have a find a doctor. So it's ARTHREX. I say that because there's a few other companies that make this equipment, and I chose not to learn this technique until Arthrex got involved, just because they have a reputation for really high quality. And so I tell you that they don't pay me to say that. That's just the honest truth. I got involved because I think they made a good stuff, but they have a website where they have a find a doctor website, and they have this company also has a very good training course where they train docs. They have a very systematic training course, and so they can connect patients up with a doc who's been to their training courses, and help you find them. There's plenty of docs in Florida that do this. And So there's plenty of docs in Florida that do this. The other companies that make this stuff are one's called Eloquence. I'm blanking on the other one. But anyways, they may have find a doctor. They may have find a doctor as well. I think honestly, just Googling endoscopic spine surgery and the state should help you find it. I kind of got with our people and said, hey, we need to make sure that we come up on people's home screen if they Google endoscopic spine surgery, New Hampshire. Because the first time I Googled it, after I've been doing this for about 6 months, that took you straight to the New York site with that endoscopic only surgery practice there. So,
Is there any specific therapy help with the recovery?
typical physical therapy, like like you would do after a discectomy, is good for the recovery. The main issue that I've found with endoscopic recovery is patients feel better quicker, and I have to slow them down because they can still reherniate. And I've had 3 now reherniate early because they felt good and they just went back to doing what they were doing, and they thought, well, if I just obey his restrictions 90% of the time, I should be fine. And well, that 10% that you bend over and pick up a sock while you're helping your wife with laundry or whatever can cause you to blow out the disc, because it's still been a discectomy. Just because the incision at the skin and just because the tissue damage to get down to the spine is significantly less doesn't mean the surgery was any less. And so patients get it when they have a bigger incision and their back hurts. They keep them, they're really careful. But when their back doesn't really hurt and they have a tiny incision, I think a lot of times they feel like they can just do whatever. They can just kind of progress themselves quickly. I had one young man, I watched him and I knew he was going to reherniate because I just knew he was, and he did. And it wasn't a big reherniation. We actually didn't reoperate on that one. We just let it get improved without surgery. But that's probably the biggest risk, is that they feel better and they forget that it still takes about 3 months for that annulus fibrosis, the lining around the disc, to actually heal itself down enough that you can stress it.
Okay, I think that's all of our questions for now. I don't have any more. So again, thank you so much.
Well, outstanding. I'm happy to be able to present this to you. I'm really passionate about this type of surgery, and I think what really stands out about it is this is not something where we make a whole lot more money off of this surgery. In fact, I think the surgical charges are even less, certainly less than a fusion. I think it's such a powerfully good thing for patients that I think it's worth it, and that's why I really believe in it. So again, I think that there's also a lot of things that are going to be able to be done with this technology. As more people embrace it, more people are going to figure out treatments that can be done that can save patients surgical morbidity. And so I'm really excited about that.
Great. Thank you so much.
You're very welcome.